All right, yes, that was something that came out in our workshop yesterday, was the need for us all to have these discussions. So I'm going to invite our next speaker up, Dr. Williams, Dr. Amanda Williams, to come and join me. Dr. Amanda Williams is a reader in clinical health psychology at the University College London, and she's going to talk to us today about how we all use psychology when we treat patients. She's an academic psychologist at the University College of London with a clinical session at the Pain Management Centre, National Hospital for Neurology and Neurosurgery. She also works for the International Centre for Health and Human Rights. At UCL, she teaches undergraduate and postgraduate psychologists and medical students and supervises their research. She has worked in the pain field for over 25 years, with particular interest in evaluating psychologically based treatments, including systematic reviews, meta-analysis, and national and international guidelines in the application of evolutionary models to pain, in expression of pain and its interpretation by clinicians, in pain from torture, and in the use of responsive technology to extend healthcare. She has written over 160 papers and chapters on aspects of pain and psychology and presents at national and international pain meetings. And she's going to speak to us today about how we all use psychology when we treat patients. Please join me in welcoming Dr. Amanda Williams.
Thank you very much. It's lovely to be here. It's my first visit to the Caymans, and I've really enjoyed it and very much want to come back. So here you see a multidisciplinary team grouped around someone who's suffering. We all respond as humans, and Dr. Cleary has just talked a lot about that. We all respond as humans to people who suffer. We also want to bring our professional skills to this. And in doing so, we need to use psychology as well as we can. So I'm going to talk about mind and body and how psychology fits into medicine, about how we can change people's behavior when that's necessary to improve their health, how people understand their health and symptoms and why they do and don't bring that to clinicians to help figure out what's happening, adjusting to chronic illness, which is, as you all know, an increasing problem, and a little bit about the clinician-patient relationship and trying to think about models that we can share better with patients, because the more that the patient and the clinician, whoever it is, doctor, nurse, psychologist, physiotherapist, alternative therapist, the more that they can be in partnership, the smoother that treatment will go. So, a lot of people think psychology is just common sense, and of course sometimes it does coincide with common sense, but often in the field of medicine it's thought of as whatever isn't biological. So it's a kind of bin into which we put all sorts of awkward things about patients and things we can't explain, placebo effect for instance. And just really everything else goes in this psychology bin, and as a psychologist I'm quite used to having people referred to me with this kind of notion. But this really isn't a helpful model. We need to be much, much more integrated. Every medical problem has a psychological dimension. Now sometimes that's really trivial and nobody needs to worry about it. The patient can perfectly well take care of his or her own psychological aspect of the problem. But even trivial symptoms can cause anxiety. As a clinician, you may think they're trivial. The patient doesn't necessarily feel they're trivial. There are a surprising number of people who, every time they have a headache, start to worry about a brain tumor. Now, it's a brain tumor in very, very few cases, fortunately, but that anxiety is there, and it's real. And those anxieties, as well as the symptoms themselves, have an impact on patients' lives. They change their behavior, they cause distress, they may make the person feel they can no longer work, or they can no longer be a good parent or a good grandparent. And there's a nice model that I'll say a little bit more later that applies to pain, which is the area I'm most familiar with, which talks about how, because pain and many other symptoms do the same, because pain interrupts, it interrupts what you're thinking and what you're saying and what you're doing, it starts to interfere with daily life. And the more aspects of daily life it interferes with, the more it starts to make you feel you're not who you were as a person. Your work, you may have to stop it, or it may not be the quality it was, or you may not enjoy it as you did. You may give up some activities. You may feel you do less at home than you would like to. And people often talk in chronic illness of having a changed identity and not being the person they were. And of course, it's hard for you as a clinician, those of you who are clinicians, when you don't know what the problem is, but that uncertainty is really hard for patients too, and tends to provoke more extreme behaviors, which may be quite hard to handle. So the more that you can explain to patients, incorporating not just the bio, your area of expertise, but also the psychological and the social, the better you can help the patient understand. And it also normalizes those anxieties and the distress, instead of the patient feeling that somehow they're fussing, or they're being neurotic, or they're being silly, or they're being, they're overreacting. But it's pretty tough assignment, really, to be trying to diagnose and to explain to the patient in terms that patients understand and feel comfortable with, also to empathize with them about their current situation and initiate treatment. This is a model of pain processing, and we see a lot of research going on one of these four aspects, the chemical and structural aspects of pain, anatomical research, drug research, and so on. Much less on mood, on context, and on cognitive set, what people think, what they attend to, how their beliefs affect the symptoms they attend to. And we could really apply this to many aspects of body experience: dizziness, weakness, tiredness, many of those symptoms that affect most people at some time or another. And this is a very nice demonstration of how just what you believe affects what you feel. So this was a study with healthy subjects. They were university students, and they had a laser stimulus to the foot. Laser stimulus tends to feel like very sharp pricking. It's a noticeable pain. It's not desperately unpleasant. And some of them were told, this is fine, we got ethics for this, not a problem. And the others were told, actually, ethics had some real problems with this, but we're going to go ahead and do it anyway. So they felt rather uncomfortable, because they thought, well, why would ethics be concerned about this? So they felt rather threatened. And what was seen was not only the people who had been told that ethics had problems with it, not only did they feel more pain, they reported more pain on a simple scale, but the parts of their brain that responded to threat were much, much more active. So it's not just what they felt subjectively, their brains were dealing with it differently because they felt threatened. And we need to remember how much patients do feel frightened, threatened by pain and by other symptoms. It's easy for us to, because we see people all day with symptoms, not to register always how much it matters. And this is the start of a pain management program. So we put pain in the middle of the board and say to patients, just say what pain means to you, what it does to your life. And you could see what I like about this is it expresses what a complete tangled mess it is to patients. Very hard for anyone to think, well, that point is the point I start, and if I deal with that, then the rest will unravel and will start to come clear. Patients feel they're just in the middle of that mess and there is no way through. So I've talked about some of the sort of softer aspects, as it were, of pain and other bodily experience, but actually it makes a real difference. This is across many different disorders. People's distress, which is measured on this thing called the GHQ, the General Health Questionnaire, which asks people about everyday symptoms, mostly psychological. And the higher their score towards the right, the more likely they are to die within the time of follow-up. This is from 68,000 people, among whom there were 8,000 deaths. So it's large data. If you look at just cardiovascular disease, which we heard a lot about yesterday, you can see again there's a clear relationship. The more distressed people are, the sooner they die. And this is leveling out for age and sex and disease level and so on. And if you look even at cancer, where we know a lot about the biological nature of cancer and about cancer progression and treatments, they're very much in the biological domain, but still people's psychological state, if they are quite distressed, not at the lower levels, but their psychological state makes a difference to how soon they die. So psychological state is not just soft stuff. It's not just about how you feel, and if you distract yourself, then you'll forget about it. It actually has a really big impact. And it's not just about feeling bad. How happy you are makes a difference. And there are a few countries now which are starting to try to use a happiness index because it increases survival, not using the index, but being happy. So this was a study where they asked 52 to 79-year-olds just to measure their happiness on a 0 to 10 scale 4 times in one day. Then they took the average. They followed them up 5 years later. These weren't people necessarily in treatment, though no doubt some of them were treated. And they looked at survival. And survival was much better among those with higher happiness, and it was in the middle with those with medium happiness, and lowest with those with low happiness. So your psychological state has profound biological effects that we don't understand really very well at all. And it's not just what's going on in your mind and in your heart and so on. It's also in your social life. And here, some of the differences that you can make to healthcare, like smoking less rather than more, the bottom line, no alcohol versus excessive alcohol. So these are contrasts. Social effects have impact in the same league. High versus low social support has a huge effect on survival. Particularly this has been mapped in cardiovascular disease, but it's true in other things too. Now, this was a very large meta-analysis of 148 studies, so over 300,000 people. You can really get some good effects across that kind of span. How they measured social relationships, there are 2 ways to do it. One is asking people how many friends they have, how many they're on Facebook with, how many people they send a Christmas card to, that kind of thing. Do they live alone or with other people? There are lots of ways of measuring it. They give you much the same answer in terms of support. Or you can ask people, who do you feel supported by? Are there people you can talk to when you feel unhappy? And what seems to matter there is having at least 2 people who you can talk to when you feel unhappy, or you can go to when you're in a mess or in a dilemma. And there are a surprising and distressing number of people who have nobody they can go to. I do some work with refugees, and very often they've been separated from their family, often even from anyone who speaks the same language or comes from the same culture, and they have nobody to speak to when they feel bad. And their mortality reflects this. So I'm going to talk a bit more about changing behavior. Here's an American study of health initiatives that will save them health dollars, which, as you know, is a pretty important aim. If you look at those are all behavioral. They're about changing behavior in order to spare surgery and other expensive and distressing and disabling problems. So all the targeting behavior change. But we know that in general, it can be quite difficult to change people's behavior in the right direction. If it were just a matter of knowing what we needed to do, there'd be very few people who smoked, nobody who smoked, nobody who was overweight. We all intend to do more healthy things than we actually do. And so we need to think about what does change behavior. Well, just information isn't enough. Who thinks that people pick up a cigarette packet, sees the notice that says cigarettes damage your health, and says, gosh, I never knew that, I'd better stop? Of course they don't. That's just a sop to attempts to improve health. And it's no good talking about willpower, motivation. We can all wish we had more. That isn't really the issue. It's really important for people to change, to understand their needs at the moment and to understand what lies ahead. And I'm sure a lot of you spend a lot of time explaining to people the long-term risks if they become diabetic, if they're obese, and so on. And then defining goals and the behaviors, the steps you need to reach those goals. It's very easy to think of how we'd like to be. It's much harder to map the route there. And when people do map the route there, when they develop a plan, they need to think how they deal with obstacles. It doesn't really apply here, but one of the things that comes up a lot in the UK is people say, okay, I'm going to start going for a walk every day. And you say, well, what about when it's raining? Because those of you who know the UK know that that's pretty common. And they say, oh no, I won't go out in the rain. Well, what about if it rains 5 days next week? Well, I won't go out 5 days next week. Well, the walking plan is already wrecked. What's the use of it? So unless people start to think their way through the obstacles and plan, say, yes, okay, I'll get a better umbrella, I'll go out in the rain, I'll whatever. So people need to know they can do the behaviors that they need to do on the steps. They need to feel that it's going to take them where they want to go, and they need the opportunity. And James Moore's talk on the first evening was brilliant for showing us how opportunity is so important, opportunity to walk, to cycle, to enjoy time outside. And one of the most important things you can do with a patient who wants to change behavior is to encourage them to monitor it. Now, some things do it for us. Fitness apps, for instance, will monitor the number of steps we take or how far we've walked or whatever. But monitoring makes a big difference, and it gives people encouraging feedback on making progress and helps them to think about what they need to do that day. So that can make a big difference. When programs for change don't involve monitoring, they very, very rarely succeed. So it's a very simple thing one can encourage people to do. So what brings people to clinicians with symptoms? People tend to think they're healthy if they feel okay, they don't have symptoms, but you know, what's a symptom? Is feeling tired a symptom, or is it just something you can account for because you're up too late last night or whatever? And being able to function normally, and of course what's normal is very different across people. And so people need to interpret what they feel in their bodies and think about it in terms of what they know. Older people tend to judge it more by the absence of symptoms. If they don't feel too stiff, too tired, then that feels healthy enough. Younger people are much more concerned with what they can do, with being able to work hard during the week and then be active at the weekend. And also they judge health by the things they do to promote their health, watching diet, watching alcohol, and so on. I'm going to use a pain example again, just to because this is material I have easy access to. These are some of the things that patients have said to me about their pain, and it just shows you how you can't guess easily what patients believe. So patients are often really worried that a pain that you see as a pretty everyday mechanical low back pain or a predictable joint pain or whatever, they worry that it's really a serious injury which is only going to get worse and disable them very severely. This is a surprisingly common one. People who say, I wake up in the morning, I have pins and needles in my arm, and every night I go to sleep thinking I'm going to wake up paralyzed, because people think pins and needles is some sort of nerve dysfunction, and the next stage will be paralysis. Now, you know, that's not actually a risk, but pins and needles is not a sign of imminent paralysis, but that is a very common belief, and it's a very worrying one for people. And people are told things that aren't necessarily helpful. Telling someone their back is worn out is often an attempt to tell them it's not some serious injury, it's not something that needs surgery. But if something's worn out, we try to be more careful using it. We do that with our cars and with other things, so we'll do it with our backs. So someone who's told their back is worn out will often try to move their back as little as possible. That's not going to help their back. So these models, which are often given with very good intentions, may be interpreted in quite a threatening light. People also worry about what it means psychologically, and we often think it's good news. We feed back to someone, there's nothing bad on the scan, there's nothing bad on X-ray, and that is actually good news. But for them, it means not only have they got pain, but now it turns out to be something rare that their doctor doesn't seem either to know what it is or to be interested in finding out. And that's very scary. They now feel alone with this rare, dangerous disease. And they worry that nobody believes them. And some patients I've met actually do have come to believe that they have somehow imagined their pain into existence. I don't think that's possible. But they've been told so many times that they must be imagining it, that they believe it. Terribly undermining. And people worry about what it's doing to their lives. We've just seen in Dr. Cleary's talk the man who took himself away from the family to spare them seeing his pain. And people do worry about the way they're a burden on the family and how people will be better off without them. And people also just can't see a way forward. I've seen many, many manual labourers with pretty low literacy skills, no computing skills, and they've been told to get an office job because they're no longer up to outdoor work, but they've only ever done building work or scaffolding or whatever it is. There's no chance they're going to compete with clever 20-year-olds with computer skills. And once people have symptoms, they kind of compare them with what they expect normal feels like and what they think illness feels like, as I described with the pins and needles. And their beliefs about what illness it might be then directs their attention, so they notice some things and don't notice others. And most people will focus on any illness, trivial to life-threatening, wanting to answer certain questions. They want to know what it is, and people put a lot of weight on a diagnosis and a name, even though the name may just be what you said in English translated into Greek and Latin, as many medical terms are. They want to know the timeline. Is it going to go away? Is it going to be for life? People often want to know the cause, and that may not be something you're particularly concerned with, but for many people, knowing the cause of their symptoms means they feel they have some control, because if they can then avoid that cause, they can avoid recurrence or worsening. And control in other ways is important too, and they want to know the consequences. They want to know where this is going. And of course, we bring our beliefs about illnesses from our childhoods, from how our parents represented things, from seeing perhaps many of my older patients remember their grandparents or even their parents really crippled with arthritis, and they associate it with strong pain, no pain relief, and awful disability. And of course, it doesn't have to be like that. And if someone says to you, you know, there's a horrible cold going round, you're more likely to notice if you have a tickly or sore throat or a runny nose or something. It's just how our brains, you know, put some things into the priority category and put other things to the back. And you can actually really change the way people experience symptoms by notions of risk. So this is from the 1899 issue of the British Medical Journal. And doctors are being warned about the dangers of the telephone, terrifying new technology. So not in women only, it's an interesting one, isn't it? You expect more symptoms in women, but in strong-minded and able-bodied men. They were getting all over pressure, which caused nervous excitability, buzzing in the air, giddiness, and neuralgic pains. Isn't that lovely? You see the same now in the UK. People complain of it from wind farms. In Scandinavia, there are people who say they're allergic to electricity, and they complain of these problems, and they go and live in the woods with no electricity. These kind of, because these symptoms happen to us, as it were, all the time, often in very trivial ways. If we have something to attribute them to, we're much more likely to notice them and to worry about them. So what makes us actually go and ask for medical help? Well, people tend to get about 10 other opinions before they actually go to a clinician. Obviously, there's a fair bit of variation in that, but looking up the internet, talking to family, talking to friends, mentioning it casually in a conversation and seeing if people say, oh, you ought to go to a doctor. But if symptoms are embarrassing, they don't tend to talk to other people. There's much more use of the internet. And if the individual's isolated, they don't do this. And for people who are very anxious about their health, and we've all met such people, they often consult very often, but they're not always so good at following treatment because they also worry about adverse effects of treatment. So they'll read very carefully the stuff that comes with a dose of drugs, and they'll worry then about all the side effects, however rare. And again, negative investigations often don't reassure people. It really depends how they're explained. So patients select what they bring according to what they think is worrying, and they're much more likely to present physical symptoms than psychological symptoms, or even to mention that they feel stressed, or they feel isolated, or they find it hard to fill their time, or whatever. And doctors and other healthcare staff, most of the researchers on doctors, tend to respond much more to reports of physical symptoms than they do to psychological ones. And I've done quite a lot of joint consultations with pain clinicians and some other clinicians, and I've seen this happen again and again. A point where the patient looks to me as if they're on the verge of tears and they've just mentioned something about how worried they are about the future. And many clinicians find that quite hard to handle, and they'll look at their notes and say, and what dose of, paracetamol did you say you were taking? And the moment is gone, but that's actually an important moment to wait and see what comes next, assuming one has the time. So people do underreport symptoms. They underreport symptoms because they're embarrassing, because they don't think they're important. There was a little while ago, there was a very interesting short piece in the BMJ by a woman who said she had a persistent cough. So she went to the GP prescribed antibiotics. The antibiotics didn't make a difference to the cough, but she was busy. She had sole care of small children, so she didn't get round to going back. And she smoked very few cigarettes a day, sort of maximum 3, and some days none at all, so she didn't think she had any risk of lung cancer. Then she started to get a sore shoulder, but she thought it was because she carried a heavy bag for her work, and she started to get a very hoarse voice, and she didn't think anything of that. And by the time she was diagnosed, she had really advanced lung cancer. But because she didn't think she was at risk for it, she didn't think the shoulder might be anything to do with it, or the hoarse voice might be anything to do with it. She didn't think of going back was urgent. So people's beliefs really do affect what they do and don't bring. And if people have had treatment for things before, they're much more likely to bring them. So in the UK, there's been a really strong attempt to stop doctors prescribing antibiotics for simple upper respiratory tract infections because of the worry about antibiotics just ending up breeding, more and more resistant bugs. And the doctor said, but patients absolutely insist on it. And patients said, but doctors always give me a prescription. I can't leave the surgery without. So people started to research this and look at what happened. And in fact, the patients who were coming back again and again were the ones who did get a prescription. The ones who refused a prescription tended not to come back with their next cough or to ask again for antibiotics. So, these things are often very, very much both sides of the relationship are creating an unhelpful pattern. So this is just to show how how many processes are happening before someone actually arrives with you. And during those processes, they're learning more from other people. It's not necessarily accurate, not necessarily correct or helpful, but they are gathering information. So people are thinking about their symptoms, trying to manage them themselves, then talking to other people, getting other sources of information, and only towards the right of this diagram are they actually turning up and asking for help. And a whole lot of factors in the culture and in the patient themselves will influence this. So what about adjusting to chronic illness once people have it? People need to adjust to the diagnosis. They worry about whether they're going to lose the important things they do in their life, or whether they should try and keep going as far as they can. They worry about managing symptoms. It all requires quite a lot of adaptation, new skills, which people find hard to do, and particularly when the position's uncertain, when diagnosis takes a long time, when there are complex referrals from one specialty to another, and it's hard to put together. And people need to establish a good relationship with their healthcare team, because they're in it for the long term. And they also need to be looking outside and thinking about their social support. And I often have seen situations where it seems to me that the healthcare team is not only providing all the healthcare, but they're also providing social support. And the only times the patient ever goes out is to hospital appointments, where they are now friendly with the receptionist, with all the clinic nurses, and so on, and rely on them quite a lot emotionally. That really isn't very sustainable. So people's beliefs will affect how they adjust. And the idea of cancer being caused by stress is a very, very common one. It's been researched quite a lot in breast cancer, and it's quite worrying in some ways if the patient then thinks the most important thing to do, as well as getting treated, of course, is to try to avoid the stress. So women who feel that their husbands are the major cause of stress, which is not at all uncommon, will feel that actually the way to prevent recurrence of breast cancer once treated is to leave their husbands. Now, that may be the best option for them and for their children, but it may well not. And it's important that they understand that there isn't good evidence that breast cancer is caused by stress. And then, of course, things like thinking you should rest, knees, backs, whatever, that's not going to help. It's going to lead usually to putting on weight and getting stiffer joints. People with weak hearts should try to avoid getting worked up. That's often a belief not just of the person who's had a heart attack or who's had a worrying diagnosis, but of those around them who don't want them to exercise, who don't want them to get excited, who then say the grandchildren can't come round because they're too noisy and stressful and so on. All those things deplete people's quality of life, avoiding things that aren't actually a risk to them. And often when people are given information that they have a genetic susceptibility or genes are part of the cause of their problem, rather than taking control over the rest of the risk factors as one would like, they often feel quite fatalistic about it and say, well, there's nothing I can do. And the counselling for the breast cancer gene has really changed because of finding out that women really stopped doing any of the things that they needed to do to minimize their risk. And there's a very interesting website devoted to this by a woman called Cherry Register who talks about these extremes. So you can keep your problem secret, but then you can run into problems with people expecting you to act as a healthy person and keep up with them, or you can talk openly about it at the risk of self-pity, but also being pitied by others. You can ask people for help and worry that you're a burden, or you can try to be independent, but really struggle, and so on. So this sort of thing can be quite helpful for people who are diagnosed with a chronic illness to look at. It may sound like a depressing thing to suggest, but actually it normalizes their feelings. To find that other people feel the same thing in the same situation is usually a comfort. And many different chronic illnesses present the same dilemmas. So what we know, and this is a review of many, many studies of adjustment to a range of chronic illnesses, is one of the most important things for adjustment is that people try to carry on the things that are important to them. They don't wait till they're stable or till treatment is finished. People who stop work that they would have liked to continue, once they've stopped for 6 months, even if then things are stable and they're feeling better, the likelihood they'll go back is much lower than if they'd managed to keep a connection. Now, many employers and some types of work are not well set up for people keeping part-time contact, but it's much more successful in the long term if people want to stay at work. And the same for other activities, for social activities. So trying to help patients not say, okay, I'll wait till all this is done and, you know, in 2 years or whatever, when I'm clear, I'll pick up my life again as if, you know, as if it was just a moment's break. It doesn't work like that. So people need encouragement to try to think about the quality of their life, what matters to them right from the start. They need to be encouraged to manage their illness as far as they can. And when people aren't doing the things that they acknowledge they know they should be doing for treatment, it's very often to do with depression or depressed mood. And that may need, it may be work that you can do, it needs referral to someone more specialist. But it's really important to look out for it. Diagnosable psychological disorders are very underdiagnosed in people with medical illness, and medical illnesses are very underdiagnosed in people with psychiatric illness. This is, again, an argument for more integrated models. And acknowledging emotions in ways that help people take control, asking people what their anxieties are. It's a huge relief for people to be asked what they're worried that they've got, what's your worst worry about this symptom? Where do you see yourself in 5 years' time? Those sort of questions enable people to start airing their worries. Sometimes you can resolve them really straightforwardly with information that you have and the patient doesn't have. You can share it and, you know, instantly their outlook changes. It's often not like that, but it's really important to get the chance to understand what's going on. And this sounds an odd one, positive outcomes of being chronically ill or disabled. And it can be a hard thing to raise with people. It's certainly not the thing to do at the point of diagnosing cancer. But it's worth telling people that many people with chronic illness or disability feel that they have, as well as losing things that were important to them, they feel they've gained as people. They feel they're more compassionate, they're more sensitive, they're more thoughtful about difficulties and disabilities. They may find they've spent more time with their family than when they were fully able-bodied and, you know, working long hours or whatever. So just recognizing that not all the changes people will make are necessarily negative ones. And we often talk about coping, patients talk about coping. We kind of think we know what it means, but it's very hard to define. And there's no universally good or bad coping. It really depends on what the problem is, how well it fits it, and does it get you the result you want. It's really important, though, to have accurate information about what you're facing. So to know whether your headache is more to do with some trigger among foods or whatever, rather than, you know, worrying it was a brain tumor. So, and knowing that you need to keep moving rather than rest your knees or your back or whatever it is. So having accurate information really matters. But then very often, because clinicians are spend such a lot of time solving problems, they very often focus on the practical. But surprisingly, the evidence isn't there that a lot of practical problem solving helps people adapt. What really makes a difference is talking to people about how they feel emotionally and trying to work with that and trying to reduce people's distress, their anxieties, their feeling they're losing all the things that are important, they're changing as a person, they're becoming a burden, those kind of things. Those are what really make a difference to adaptation. So Doctor or clinician-patient relationships, of course, differ whether you're seeing someone once or repeatedly. And the quality of the relationship is very important. And just as Dr. Cleary said, certain groups tend to be disadvantaged. Older people, people from ethnic minorities, and often women. And there's evidence that women who go into A&E with a chest pain are more often, some of them are sent away told not to fuss, and they go home and have a heart attack, whereas a man complaining of exactly the same thing will get an ECG, because the stereotype is that men have heart attacks and women don't. But there's also a stereotype that women fuss a lot about symptoms and can be dismissed. So, I mean, obviously that's a huge generalization, but when you look across large numbers, you can pick up these effects. People who don't share the same language as the clinician, or who are from a different culture, very often are assessed less well. They're given less chance to ask questions, and they're definitely given less information. And yet they're already people who are at more risk in terms of their health and have more problems following treatment, often because of the financial demands of treatment. If a patient is dissatisfied or feels not believed or not cared for, and sometimes it's very hard to make some people feel cared for and believed, they tend to stop trusting the clinician. And then if they don't trust someone, they won't adhere to treatment. So when someone is not adhering to treatment, it's not usually because of their age or their personality or something like that. And it happens at all severities of illness. You see a lot of non-adherence in cancer treatments, just as you do in very minor disorders. Adherence is much more related to what's going on in the clinician-patient relationship. Feeling listened to, feeling cared about, feeling that someone has fitted your particular needs and symptoms into their understanding of disease. And the other thing that matters is patients' overall social support outside the healthcare system. There is actually quite a literature on what are called difficult patients. It's now challenging patients. And it's interesting because it attributes the difficulty, the challengingness, entirely to the patient. And the research quite seriously sees this as something that patients are, not as something that happens in the relationship. And so doctors are asked to, people haven't done this with other healthcare professionals, so they're asked to note out of a clinic list who they found difficult. And it's not usually because they're older patients or younger patients or women or whatever, or because they're not well educated, which is the kind of things that doctors often say they think they find difficult. It's having a lot of somatic symptoms. The person who has a couple of pains is dizzy, complains of tiredness and not sleeping, and who had a funny rash that's now gone away so they can't show you. That's the sort of thing that is likely to start this classification. And that when the patient experiences their symptoms of severe, is worried about them, but without being asked won't necessarily share those worries, and says they're quite disabled by it. So they couldn't go out at all because of the rash. They can't function at all because of the tiredness. And anyone with, as I said, with a diagnosable psychiatric disorder is seen as difficult and is less well assessed. So there are various names for this. Heart sink patients now seems to have given way in the UK to calling people frequent flyers. But whatever it is, it's blamed on the patient when in fact it's happening in the relationship. So of course it would be nice if patients were always easy to deal with. They're never going to be. We're all people, we're all patients at times, and some healthcare professionals can be very difficult patients. So as clinicians, we have the power to try to make the relationship better. And people don't necessarily come and tell you their worries and tell you how difficult life is with this symptom or long-term problem. What discourages them from disclosure is questioning or disbelieving their symptoms, saying, are you sure it's swollen? Doesn't look swollen to me. There's actually very interesting information now using functional MRI scanning of the brain that shows that the representation in the brain is of something much more swollen than it is. It's much more like the experience of someone with major swelling than of someone with very minor swelling. So people are actually often reporting very real experiences, but they don't coincide with what we can see. If you disapprove of the patient's expressing distress, pull yourself together, there's no need to cry about this, it's not so bad, that kind of comment. Ignoring disclosure and responding by asking medical questions, which is an easy thing to do because a lot of people want someone to, want to close down the consultation once it gets into this difficult area. What encourages people to disclose their anxieties and their difficulties is just saying, it can be hard to cope with this. How do you feel? How are you managing? Letting the patient express distress, give them a bit of time. And it could be hard to know what to say to those statements, but even just saying, sounds to me like you feel, and then using their words again, firstly, it checks that you've understood it, and it is easy to misunderstand sometimes people's description of their emotions. But secondly, to the patient, that is very, very accepting. And all those tend to lead through the better doctor-patient, clinician-patient relationship to more adherence and greater satisfaction. So this is just an example of it. So GPs were lined up, randomized, and asked either to respond to women with severe menstrual pain in a warm and empathic manner and expressing some positive expectation that non-steroidal anti-inflammatories would help the menstrual pain. And the other randomized group were told to be cold and formal and distant with the women and to say, well, these non-steroidals might help, they might not, help some people. And the warm and empathic GPs produced not just a significant decrease in pain, but also anxiety. So the women were less anxious and they get more relief from the... Now, the women didn't know that they're in that there were these two different conditions. They genuinely had less pain as a result of the warm and empathic and encouraging consultation. And this is a wonderful study. People actually managed to image the spinal cord, and you have to take it a bit on trust because there's a blob on a spinal cord. But this is actually showing how processing, even in the spinal cord, we're not even in the brain yet, was different in placebo responders from non-placebo responders. So placebo, if you believe that you're being treated with something which is helpful and that is actually going to help you, the whole processing, even in your spinal cord, of incoming stimuli from your skin, from your muscles, from your joints, that changes. And here they say psychological factors can influence nociceptive pain processing at the earliest stage of the central nervous system, dorsal horn of the spinal cord. I think that's fantastically exciting. And for me, this is starting to make the links between psychology and biomedicine that we badly need so that the two aren't treated as so separate. So, of course, you may at times want to refer to psychology, and I know there's some psychologists here, and there are many different schools, and of course, I just show you a few schools here, but there are many, many different combinations and varieties. It can be bewildering. It's bewildering even to psychologists sometimes. And it's hard to explain what is and isn't available and get patients to choose because they may not know what suits them. So this is it's a tricky area. It often requires some skill on your part to know who to refer to. And no doubt, in a year's time, there'll be even more combinations. But it does mean that it's worth telling someone that there are several things they can try. And just like with drugs, if the first one doesn't help, it doesn't mean they're a failure. It doesn't mean their problem is unresolvable. It means they maybe need a different technique to work with. So this is the pain model I was talking about that I think works for a number of symptoms. And I think this is something that's really helpful to share with patients. When we just talk to patients using this model, they often find it very helpful. They say, yes, that's what it feels like, but this makes sense now of why I seem to achieve so little in a day. And I look back over the last year, and I've also achieved very little, and I haven't done many of the things that I would normally have done. So pain interrupts moment to moment. Pain grabs our attention because it's had to do that. We'd never have survived if we could just shove our pain aside and ignore it, because it's such an essential signal. But a lot of the time, it's a false alarm. It's nothing that needs stop us in our tracks. But it tends to grab our attention until we do something about it. And then the more it does that, the more it disrupts our thinking, our conversations, our focus on other things, our work, and so on. And the more it disrupts those, the more it affects who we feel we are as people. And so that's an attempt to try to bridge some of these gaps in a very simple way to explain to patients. So what is often referred to as a biopsychosocial model is really accepting that illness is always multifactorial. There's always going to be a psychological, often a social component, and all these interact. Health and illness are very much on a continuum. It's a very fuzzy area. Few of us ever feel 100% well. There's usually some niggling thing that we are managing ourselves without any particular worry. And we may have some control over what makes us uncomfortable, and we may exert that control and change our behavior. But both patient and clinician bring expertise to this. The patient in what might be possible to change in their lives, and you in a whole body of knowledge that needs applying to the problems. And we must stop treating mind and body as separate. I mean, our health services are often set up utterly separately. In the States, it's extremely hard to get psychological care for somebody who's in medical services, or medical care sometimes for people who are in psychological and psychiatric services. So we even set things up so people are only allowed to have a mind problem or a body problem, but not both, and certainly nothing interacting. So we really need to change our ideas completely in order to, and for that to be then fed through into the way we organize our services and we think about disease. But I think that's the way we're going. And for me, pain is a very good example of multidisciplinary work where people often are exchanging ideas, learning from patients and trying to build these models. So thank you very much.